Hi guys, welcome back to my channel. My name's Anna, I'm a clinical psychology doctoral intern, and today we're going to be talking about OCD. OCD is a very misunderstood diagnosis. A lot of people think it's just being very clean and having specific compulsions that are very easy to notice and identify as this is OCD, but it's actually a lot more complicated than that. It's a style of thinking and responding to your thoughts that can encompass a lot of areas of your life, a lot of different behaviors and thought patterns. Today we're going to do, I don't know if I would call it a deep dive, but we're going to go definitely a little bit deeper than most people go into OCD and what it could look like, and you might find some surprising things even if you yourself have OCD. First things first, what actually is OCD? OCD is short for obsessive-compulsive disorder. So OCD is characterized by obsessions and compulsions. Now, obsessions are the mental piece, usually intrusive, repetitive thoughts that are very difficult to get rid of and very distressing. They cause a lot of anxiety or disgust. Compulsions are the way that you respond to those thoughts through behaviors, and those behaviors can also be mental at times. So you can respond to an obsession with a mental compulsion, which we'll get to in a moment. OCD is a very neurologically based disorder. We know that it is associated very heavily with certain dysfunctions in the brain, which is why, in my experience, when clients with OCD have gone on medications, the first line of which are usually actually antidepressants, that has been actually very helpful for a lot of them if they find the right medication. But when the problem is very heavily neurological, a neurological solution can also be very helpful. And that's actually why OCD develops usually in childhood, which is earlier than the onset age of most other mental disorders in the DSM. Neuroscience suggests that OCD is caused by a miscommunication between three parts of the brain: the cortex, the striatum, and the thalamus. This loop in the brain is involved in the initiation and termination of behavior. And so when you have imbalances in this part of the brain, people with OCD get stuck in these repetitive loops of thought or behavior. People with OCD respond too much to perceived errors in the environment, such as if they are obsessing over their appearance, they might nitpick certain things like oh, this eye's a little asymmetrical, this side of my face a little larger, this split end. Like, they really hone in on the things that are wrong with whatever the focus of their obsession is, and they don't respond enough to those stop signs that their brain is sending them. They become hyperfixated on what could be wrong, and that broken circuit fails to signal, it's okay, action has been taken, you can stop now. They don't get that almost like dopamine boost that people usually receive once a task is done. We do think that dopamine and serotonin are heavily involved in what creates OCD in the brain, and that is why antidepressants, which are SSRIs, SNRIs, they operate very heavily on the serotonin piece. So let's go through some examples of how this looks in a person without OCD and how this broken circuit looks in a person who has OCD. And again, these are just examples. As you'll see, there is such a wide breadth of how OCD can actually look. So this is just, different flavors of it. Definitely not applicable to everyone with OCD. So a person without OCD, they might put their keys on the kitchen counter and just move on with their day. And later, they see that the kitchen counter is dirty because of the keys. They wipe it down one time and they move on with their day. They don't feel particularly distressed, none of that. On the other hand, a person with OCD might feel extreme discomfort or distress or disgust or anxiety when they see those keys on the kitchen counter. And they have these intrusive thoughts about it being unsanitary, and they feel a very strong urge to move the keys and wipe the counter down. But even after they've wiped the counter down, it just doesn't feel right. They have to do it over and over again until it does. A different example. A person without OCD might get a homework assignment due in 1 week, wait a couple of days before starting it, then they might do an hour here and there before finally completing it, and then they might proofread it a couple times. Whereas a person with OCD would get a homework assignment and start it right away because otherwise they feel guilty. They can't enjoy their free time. They feel like if I don't do this right now, it's not going to feel like I can relax. They might make an extensive list for all the tasks the assignment entails and not stop until they get to a specific predetermined, rather not so important number on the list, and no matter how tired they are, they can't stop until they get to that number. That might actually take a very long time because they might reread the same paragraph over and over again to the point where they lose hours of time, and they might procrastinate submitting it until it's perfect, a perfection that just doesn't quite exist. So in order to meet criteria for OCD, you have to spend at least 1 hour a day on obsessions and/or compulsions. But it can be challenging to assess if that's happening if a person's compulsions are very mental, or if maybe they have what's called pure O OCD, which is a little bit controversial, only characterized by obsessions, no compulsions. Because again, if it's mental, if you can't see it, it's kind of hard to discern how long is this person spending per day on obsessions or mental compulsions. So you have the obsession, the mental intrusive thought, which could be an image, it could be an urge, it could be a specific word, really any kind of thought. And then you have the compulsion, which is meant to appease your anxiety brought on by the obsession. So for instance, you're driving, you get these intrusive thoughts about the car toppling over, about you causing an accident, running someone over. The compulsion you might use to try to appease that anxiety, to reassure yourself that everything is okay, to constantly look at the rearview mirror, to constantly look at the side mirrors, constantly be checking your speed, comparing it to the speed limit, looking around. All these different behaviors meant to reassure you that you're not causing an accident, you're not hurting anybody, you're not hurting yourself, that ironically make it more likely for an accident to happen because it's too much. It's not adaptive. It's to a point where it's becoming pathological. And this obsession-compulsion loop only strengthens the whole OCD. It only strengthens the obsession, and it only strengthens the compulsions in turn. The more you try to avoid triggers or you try to appease the anxiety you feel from an obsession, the stronger the urge will be to complete the compulsion, the harder it will be to resist the compulsion. The only way out of this, and this is a really unpleasant reality for people with OCD, is to actually face your fears, accept that, yeah, this bad thing could happen, and resist whatever compulsion is coming up for you. And also, by the way, OCD is technically an anxiety disorder, although OCD type disorders have their own category in the DSM. The thing is that sometimes it can be less about anxiety and more about disgust or just general distress. So for instance, someone might have very disturbing obsessions that don't necessarily make them anxious, but just make them feel disgusted, almost like when you see something really gross. So what are some types of OCD? We're going to talk about some clusters of themes in the obsessions and compulsions, and this is not an exhaustive list, but it is relatively comprehensive, and people with OCD often have an array of symptoms from these different clusters. The most commonly known one, obviously, is decontamination. Obsessions related to decontamination could include bodily fluids, germs, a specific illness, and so the compulsions are things like avoiding door handles, cleaning surfaces very thoroughly, washing hands excessively. All of these types of OCD have an adaptive kernel in them. Obviously, it's adaptive to avoid disease, but by definition, they are taken to an extreme where it ceases to be adaptive. Then there's checking OCD, which is exactly what it sounds like. The obsessions could include wanting to check that an intruder didn't come in, or fear of leaving the stove on. And the compulsions related to that could be checking the door over and over again, checking what you've said to someone else, checking your own writing for errors, checking your memory. Then there is harm-related OCD. This is actually a very common giveaway of OCD. Obsessions could include getting into a car accident, jumping in front of a train even though you don't want to. When you see a sharp object, someone hurting themselves on it, accidentally hurting pets or loved ones, accidentally hurting yourself. Compulsions could include removing potentially harmful objects, warning others of danger, calling others to make sure that they're okay. There's also perfectionistic OCD, where you're questioning everything that you've said and done and thought. You're wanting to have a perfect appearance. You're wanting your home to be just so. You want everything to be symmetrical and tidy and clean. The compulsion could be trying to say things perfectly, refusing to say something unless it's completely recited in your brain, refusing to relax, extensive list making. Counting OCD, the obsession is pretty simple. It's certain numbers get fixated in your brain. The compulsions could be counting up to a certain number, repeating behaviors a certain number of times, doing something an odd or even number of times. Body focused OCD, again, what it sounds like. The obsessions are fixating on asymmetry symmetry, muscle mass, body fat, blemishes, anything related to appearance. And then the compulsions could be checking yourself in the mirror a lot of times, reassurance seeking about your looks, picking at your skin to make it perfect, getting plastic surgery. This is where it really overlaps with body dysmorphia quite a bit. Then there's health or illness. This one overlaps a lot with illness anxiety, which is a section of the OCD chapter in the DSM. So obsessions could be certain mental or physical disorders like fear of going crazy, fear of becoming psychotic or manic, or having an autoimmune disorder, or pretty much any medical disease under the sun. Fixating over certain symptoms, over fear of brain damage, over going crazy. And then the compulsions could be reading about illnesses online, what we call information seeking, compulsive information seeking, reassurance seeking by repeatedly going to different doctors, hoping for reassurance that you don't have what you think you have, checking your body for symptoms, taking your temperature. Obviously, there are a lot of behaviors that could fall under this one. Then there's aggressive OCD, and this one is also a dead giveaway for OCD because it is so particular. With this, obsessions could include accidentally or intentionally hurting others, acting in inappropriate ways, thinking that you're immoral or you're a psychopath. Compulsions include checking your memory to make sure you haven't done something aggressive, reassurance seeking, avoiding people in hopes of protecting them. Sexual OCD obsessions could include being attracted to someone that it's not socially acceptable for you to be attracted to. This one is important to clarify. It's not that people with OCD are actually attracted to the people they worry they're attracted to. So oftentimes because of the historical taboo about being gay, a lot of older generations' type of OCD was this fear that they might be attracted to people of the same sex, when in reality, they weren't, and they weren't necessarily homophobic. Certainly, they probably internalized some homophobia, but they wouldn't have had an issue with being gay. They just had this obsession that they might be. Or sometimes an obsession will be that you're attracted to a family member, or to, you can imagine people or non-people that you should not be attracted to. It's not that they're actually attracted to these people. They just want to make sure that they're not. It's almost like this urge to know, am I an okay person? Am I moral? Are my thoughts pure? And so the compulsions could include avoiding certain people, trying to cover up in front of certain people, checking to make sure that you're not aroused when you're around them. And there is magical or undoing, which is a category in which you have obsessions related to bad luck or unlucky objects or being possessed, things that are a little bit more superstitious. Compulsions could include reciting certain words, rethinking your thoughts, gazing at objects in a certain way, knocking on wood. So again, very superstitious behaviors. Religious, kind of similar to this, obsessions could include not wanting to blaspheme, feeling like you're a sinner, doubting your faith, wanting to be perfectly religious. And then the compulsions are praying, checking your own thoughts, crossing yourself, things like that. Touching or movement is one of those kind of unexplainable ones. People with these sorts of obsessions fear that something bad will happen if, for instance, they don't skip the cracks in the pavement, or they have to touch things a certain way as a compulsion. It doesn't really make sense. It's just this urge to touch it in a special way to them, or to touch certain patterns or textures. As you can imagine, here it starts to get a little bit overlapping with autism and sometimes even ADHD. And actually, I've had a lot of clients who had OCD where their family members had some form of neurodivergence. We don't know exactly what the connection is between OCD and neurodivergence, but there seems to be some sort of genetic predisposition behind both of them. Somehow, although they're distinct disorders, and you can certainly have both as well, somehow they just seem to be close in their etiology. Then we have mental compulsions. So these are things like making mental maps, memorizing information, thinking thoughts in reverse, analyzing your thoughts to see if they were appropriate, replaying your past behavior to see if you have a mental disorder. Like I was saying, as you can imagine, very difficult to assess how long is this person spending on these mental compulsions, because they're kind of hard to gauge. It's not like you have a timer going off every time you start and end a compulsion throughout the day. It's usually filled throughout the day. And then there are neutral obsessions. This is, again, kind of hard to explain, but it's just random stuff like certain sounds, words, nonsense images, excessive awareness of your own thoughts, excessive awareness of normal bodily functions like becoming really obsessed with, am I breathing right? Is my heart beating correctly? So as you can imagine, there are so many different ways that OCD can look. It could look wildly different from one person to the next. What is underlying both cases is obsessions and compulsions, and this loop between them. So there are a lot of OCD-like disorders, and these are, for the most part, things that are in the OCD chapter of the DSM. Illness anxiety is one of them. So this is when you have obsessions about developing certain illnesses or fixating on perceived or minor. My mic went out, but illness anxiety, you have obsessions about developing certain illnesses, fixating on perceived or minor symptoms, and then compulsively information seeking, reassurance seeking, like going to doctors over and over again, checking your own body for symptoms. So you may be wondering, okay, what's the difference between illness anxiety and OCD that has that type of obsession and compulsion? The difference is illness anxiety is usually just isolated to that type of OCD. So someone who has illness anxiety arguably has an obsessive-compulsive type of anxiety disorder. But if it doesn't also generalize to other types of anxiety, if you don't have other types of obsessions or compulsions, you would probably meet criteria for illness anxiety and not necessarily OCD. It might not be as accurate in describing what's going on for you. Then there is hair pulling, trichotillomania, or skin picking. This is when you have repetitive body-focused movements that people don't even realize they're doing or find difficult to stop. Again, remember, there's a huge similarity with neurodivergent stimming here. And for OCD, it is often used as a form of self-soothing because of high levels of anxiety, but it is also just this impulse that's really hard to break free of just like ripping your skin apart or like pulling your hair out, things that you would say to a person with OCD, like, why can't you just stop? I don't understand. It's very difficult because, first of all, a lot of the times people with OCD aren't even aware that they're doing it. It's kind of unconscious. And then it's very difficult to stop. There are very, very powerful urges to do this, and it doesn't quite make sense. It's a compulsion in and of itself. It's like, I need to pick at the scab. So obviously this can be a part of OCD, or it can be on its own, which would be sort of its own different kind of compulsion that exists in a vacuum. But let's be real, that doesn't usually happen. Usually if you have hair pulling or skin picking, there is some form of underlying OCD at play there. Hoarding is also associated with OCD. So this is its own separate diagnosis where people find it very difficult to give away or throw out objects. The obsession here would be, for instance, I need to have this item. I won't be able to handle my emotions if I don't have it. And then the compulsion would be to hoard things instead of giving them away or instead of throwing them out. If I get rid of this shirt as a birthday gift, something terrible might happen to the person who gave it to me. I'm just going to store it in the garage. Body dysmorphia, like I said, is its own separate thing, and it can also be a component of OCD. Because you have obsessions about certain perceived flaws in your appearance, and then you have certain compulsions to try to fix those flaws by doing makeup, angles, expressions, diet, exercise, checking your appearance, reassurance seeking, and so forth. Now, this one is not in the OCD chapter, but I personally believe that it should be. Eating disorders. Disorders are very obsessive and compulsive in their nature. They're usually in conjunction with body dysmorphia, especially the more restrictive ones like AN and BN. You already have the body dysmorphia piece, and then you have obsessions about weight and food, and then you have compulsions about achieving the ideal body through diet and exercise, counting calories, avoiding certain foods. I wouldn't necessarily count binge eating disorder as a type of OCD, but I guess in a sense it could be sort of like a compulsion for some people, but I definitely think the more restrictive types of eating disorders fall more closely in line with obsessive-compulsive patterns. And then there's obsessive-compulsive personality disorder, which is a little-known personality disorder. It's part of, I believe, cluster C. This is a personality style characterized by rigidity, inflexibility, high anxiety, obsessiveness, compulsivity, excessive preoccupation with order, and productivity. So you may be thinking, what? Like, how is this different from OCD? This sounds like someone with OCD. Yeah, it's very complicated, again, because OCD is referring to the thoughts and behaviors. OCPD is referring to personality traits. The two are obviously very compatible with each other. You can imagine people having both at the same time, but it's not always the case. A lot of times people meet criteria for OCD and not OCPD, or the other way around. And OCPD, like all personality disorders, are egosyntonic, meaning the person with OCPD doesn't realize there's anything wrong with the way that they're moving through the world, with the traits that they have. They kind of think everyone else is the problem. Another really dead giveaway of OCD is when people say or insinuate that things have to be just right or just so. These are really interesting expressions because they get at the sense that someone really needs things to be a specific way. There's not a whole lot of logic or thinking behind it, but it is like that obsessive-compulsive itch. Like, I just need it to be like this. I can't explain it. It just has to be this way. Like, I don't know if this ever happens with your cats, but sometimes my cats will get into this like really, really extreme urge to like get on a counter or to play with a tassel. And if you try to interrupt that behavior, like move them to somewhere else or take away the tassel, it's like they can't handle it. You can see that they're feeling really distressed. They just need to complete that behavior. They need to take it to the termination phase. It's kind of similar to that. So for instance, someone with OCD might need the coffee table arrangement to be a specific way, or it has to be symmetrical, or everything has to sit in a specific place. Or they might rinse themselves in the shower a specific number of times because otherwise it just doesn't feel right. If they need to wash themselves 3 times, it has to be 3. It can't be 2.5. It just doesn't feel complete. Or they must say something in a specific way, or else there's some discomfort. This is a symptom of that broken loop that I was talking about earlier. People without OCD don't need things to be just so. They're okay with things being the way they are, even if they're imperfect for the most part. But for OCD, things have to be just so, or it causes immense distress. So obviously we're not going to be able to solve OCD in a video, but how is it treated? Just to give you a little bit of knowledge about what might be helpful if you feel like you have OCD. It's typically recommended in more traditional CBT to start with motivational interviewing because you want people to have a very strong sense of what they've lost to OCD, how it's hurt their loved ones, how it's hurt them, and how their rituals don't actually keep them safe. Like no matter how many times you wash yourself, you can't really ever know that you're completely decontaminated. And the reason you want to do this is because the treatment for OCD is very strenuous. It's very uncomfortable, very distressing. People feel high amounts of anxiety and disgust. So you want them to be really motivated to go through that therapy, and you want them to have a really strong sense of what they have to gain from this and what they have to lose from not doing this. So once you've done motivational interviewing, usually the next step is something called ERP, exposure and response prevention therapy. This is a type of exposure therapy where you basically create a hierarchy of all your compulsions from least to most anxiety-inducing, and you rate every single one of them on a scale from 0 to 100% anxiety. Then you work your way up from the bottom every single week, usually in therapy itself as well as for homework. You get more acclimated to doing the things that bring you distress, or to being exposed to things that make you distressed. For instance, if you have an obsession about something about your face looking deformed. Let's say that you have like skin texture that you're insecure about to an obsessive level. The task there might be to not wear makeup over Zoom, to not wear makeup at work, to not try to pose a certain way or use certain lighting to detract from that. To allow yourself to feel that anxiety to about 80%, not 100%. You don't want to induce flooding. You don't want to have a panic attack. And then to finally bring yourself back down, relax your body, soothe yourself, ground yourself. And then you're a little bit less anxious the next time you come into contact with that trigger. I think that cognitive diffusion, which is a technique from ACT, acceptance and commitment therapy, is also really helpful for OCD. I think particularly for the obsessional piece, this can be helpful because a lot of times people with obsessions, they want to get rid of them. They want to push them away. But my beach ball metaphor, the harder you push something down, the harder it pops back up. And so the point of cognitive diffusion is to just let your thoughts come and pass and observe them in a neutral, disengaged, depersonalized manner so that they don't have so much power over you. You can still go about your life. You don't give them so much weight. So if you combine cognitive diffusion for the obsessional piece with ERP for the compulsive piece, what you get is the obsessions don't bother you as much and the compulsions you can kind of resist. And like I said, medications can certainly help with OCD quite a bit. I've heard clients describe it sometimes as like turning down the volume on their obsessions. Maybe they still have those obsessions, but it's far less frequently, and it's a lot less disturbing and intense for them. They're able to kind of just disengage, essentially what cognitive diffusion is trying to do in a more endogenous manner. Medications can have side effects. Those aren't always pleasant for people, and so it is a person's choice. Is this something I want to pursue, or do I want to try to work on this the natural way? But something you should know, fear of side effects or fear of you being the 1 in 1,000 people that a rare side effect happens to is actually an obsession within OCD itself. If you struggle with taking pills or taking medications, it could be also caused by the OCD, ironically. And so those obsessions could actually disappear once you start taking the medication. With that being said, it is absolutely possible to just turn down the volume on your obsessions in a natural way. It just might be a lot harder. So, let me know what you thought about this. Obviously, I don't want you guys to be using this information to self-diagnose or anything like that, but if you suspect you have OCD, definitely speak to a provider about it. And if you do have OCD, I hope that this was validating and just helped you gain a little bit more information about your disorder. Hope you have a great day. Next time I see you, it's going to be a very exciting day, I believe, if all goes as expected, and see you soon.